everyone. I'm Dr. Supriya Mannepalli, Medical Director for Infection Prevention and Control, and thank you for tuning in to our Infection Prevention and Control podcast series. Today, I have Nicole Dunn, one of our infection preventionists, and actually recently promoted to be a supervisor, joining us. Yes. Congratulations.
Thank
you. And Sarah Orstadius, again, congratulations, Director of Laboratory Services, joining us. Today, we will be discussing CLABSI prevention today in our podcast. Before we get into that, Nicole, can you share a little bit more about you? How did you end up in infection control? What did you do before?
Yeah. So I graduated nursing school in 2013. I did some time on a medical oncology unit. We did medical oncology. We had hospice. We had renal patients. So just a handful of patients. And then I transferred to the surgical trauma ICU and developed my skills further there. And then I came to infection prevention about 3 years ago.
Okay, very nice, nice. And Sarah?
My life has been in the laboratory. I started off in the microbiology section of the laboratory. And being in the micro section, I work really closely with our infection prevention team and our infectious disease team, which is really how I got connected with both of you. Yeah. And then from there, I've just kind of worked my way up into our admin roles in our laboratory. So my role has grown, but I just have stayed connected with both of our departments within our infectious disease and infection prevention team.
We're very thankful for the collaboration from our lab partners. We can't do what we do without you guys. So thank you. Again, starting off our conversation, I think we should start off with elaborating on the definition of CLABSI and how infection prevention and control identifies CLABSIs.
Yeah, so I will say that CLABSIs are the harder of the HAIs to call, and HAIs is hospital-associated infection, just because the rules are a little bit more strict with it. And so a CLABSI, to kind of put it in a simpler term, it's a central line associated bloodstream infection. And what that means is you have a central line that terminates into a greater vessel. And so then whenever you get positive blood cultures, it could be either identified organism or it can be two matching common commensals, and those matching common commensals need to come with a sign or symptom, such as hypotension, fever, things like that. And so, when you really look into a patient's chart and you look and see that the bloodstream infection cannot be called back to another site infection, that's when you have a CLABSI.
Okay, thank you for explaining that. And Sarah, from a lab standpoint, common commensals would be skin bacteria that are there colonizing the skin.
Correct. So there's certain bacteria that are just normal to have as part of your skin, and it's just normal. It's okay. But when they get into your bloodstream infection, it can cause infection. However, when we do collect blood cultures, if we don't do proper skin cleaning techniques prior to collecting those blood cultures, they can get introduced into that blood culture bottle, and then they start to grow in that media of that blood culture bottle, and it becomes a false positive at that point. And so it's not that patient actually has that growing in in their bloodstream, but it makes it look like it because it's growing in that blood culture bottle. So it's hard because we can't really rule it out that it's not within that patient's in their bloodstream until we have another bottle to actually rule it out that it's not there, or that they don't have signs or symptoms or something else that might diagnose that, but they might have it on their skin, and that's where that comes from.
And that is why initial blood cultures should always be two sets from two separate sites.
Correct. Yeah, that is the best practice for it. Yeah, we want two sets from two sites, two separate sites. So that could be from the right arm and the left arm, and the set would be an aerobic bottle and an anaerobic bottle. So we want to make sure that you have
Yes.
both of those bottles along with that.
Right. So 2 separate blood draws.
Correct.
Yes.
Correct. Yes. You want to make sure you're
Yes.
doing 2 separate cleaning techniques, 2
Yes.
separate collections, and that would be best practice when you're doing that.
And can we draw blood cultures from the lines?
Oh, it is not ideal. We do
Yes.
not want to do that. None of our phlebotomists, we don't
Yes.
have our phlebotomists draw from the lines at all. Like they're not trained to do that at all. And then there's certain protocols in which nursing staff may, but it has to be approved, and there's certain stipulations, but it's not a preferred technique at all.
And the reason for that is that when we're drawing from the line, there's a risk of contamination. And even if we suspect the infection is from the line, it's still recommended not to draw blood cultures from the lines. What about catheter tips if the line is removed?
Yeah, again, it's not best practice. There's just not a lot of evidence anymore. There's been a lot of studies from the time that we used to collect and culture catheter tips on a regular basis. There's been a lot of studies showing that maybe that wasn't always the best practice for what we were doing prior to.
Absolutely.
And so since then, the evidence has shown that we don't have to do that anymore because it's just giving us a lot of information that is not really relevant for caring for the patients. So at this time, we're not recommending that we're doing catheter tip collections.
Thank you.
And from a data standpoint, you cannot use a catheter tip to call that to another site of infection to rule out a CLABSI.
That's helpful. Okay, thank you for sharing that. And recently, our lab actually stopped that as an orderable option in EPIC. So I think to, again, discourage sending catheter tips for culture because you do contaminate it as you're pulling the line. So it's really not a reliable culture.
Right.
And Nicole, going back to our CLABSI surveillance from last year, how many common commensals did we identify in the central line bloodstream infections that we identified?
Yeah, of the CLABSIs that we called last year, 10 were called from common commensals.
Okay. Thank you for sharing that. And that would be organisms like Staph epidermidis or other strains of Coagulase negative staph or a
Correct.
bacillus species or Corynebacterium, diphtheroids, those. Sarah, can you share, I know lab has done a great job of decreasing contamination rates. Can you share a bit more about that?
Right. So to decrease contamination rates, there's a number of initiatives that we've taken from the lab standpoint to try to reduce our blood culture contaminants. One of the biggest ones that we've done is to use the an ISDD, which is oh my gosh, I lost the word.
Diversion device.
Diversion device. Thank you.
Yeah.
The initial specimen diversion device. And we have a certain manufacturer that we use. It doesn't have to be that manufacturer. And what that does is it diverts just a very small portion of blood prior to that going into the blood culture bottle. And that helps to take that skin plug, which contains that bacteria, those common commensals that are on there, that diverts that into a little chamber within that diversion device so that it doesn't go into the blood culture bottle. And then the blood then can flow into the blood culture bottle, and then we're actually culturing the actual blood from that patient without the risk of culturing contaminants that might be on the patient's skin as well. And that's going to be really important. That's what we want to do. When we started using those diversion devices, we saw a lower contamination rate by about 3%, really right off the bat. It was huge what we saw. And that was great. We loved that number. That was fantastic when we saw that. But it doesn't stop from just practicing your good hygiene practices, your cleaning techniques. You still have to do all of that. And so we do that with our phlebotomy staff as well. And so we still do all of our education with our phlebotomy staff, still do all of our training that we have to do with them. we still do our monthly rounds with our staff and making sure that they're following all of our protocols. That's all part of what we have to do, observations, and making sure that they're following the techniques. And I mean, that's just part of what we have to do as part of the education with the staff.
It's so important that we decrease the blood culture contamination rates, not just to help with CLABSI numbers, but also the unnecessary antibiotics the patient gets, unnecessary workup, repeat blood cultures, echoes. So there's so many other implications, extended hospital stay, increased risk of other HAIs, hospital-acquired infections, because they're staying longer in the hospital. So again, thank you for all that work. So yes, we are so happy with the decreased contamination rates, and we're continuing to monitor them.
Right.
Thanks to you guys. So
Right.
thank you for that. There are also several other initiatives that we have implemented, we're focusing on as part of CLABSI prevention. Nicole, can you elaborate more on those?
Yeah, so from a nursing standpoint, the leader on the floor will, and the bedside nurse will review the line daily for necessity. And if the line is not needed, then they take it out. And so if you have no line, then you can have no CLABSI, no infection,
Correct.
and all the extended medical that comes with that.
Yes, yes.
Also, dressing changes are changed every 7 days, and PRN if needed. They typically at our facility occur on Wednesdays, just because we have one day that we know when multiple people are here, we can have extra hands, and we know what day they're getting changed. And then we have gone to scrubbing our hub for 5 seconds, and then allowing it to dry for 5 seconds. We also use a alcohol impregnated cap that is to be placed on all ports that are not in use. And then we also we have implemented all patients with a central line will receive a CHG bath treatment every single day, and then those in ICU as well. And then other things that we have implemented is that emergently placed lines should be exchanged within 24 hours of insertion.
I think that's very important, because in an emergency, there may have been some disruption or breach in the sterile technique.
Yes.
So it's very important that once the patient is stabilized, to reassess and remove those emergently placed lines. And thank you for mentioning and clarifying about the CHG bath as a treatment.
Yes.
So that drives home the importance of that.
Yes,
Because that is so important, that patients are receiving the CHG treatment daily when they have a central line. And line necessity should be reviewed daily as part of the interdisciplinary rounds between the providers and the nursing, so that any unnecessary lines that don't meet criteria are removed. And we also continue to advocate avoiding femoral lines.
Yes.
We're aware of some of the recent evidence or guidelines, but at NGHS, we still continue to recommend avoiding femoral lines. It was summer, right? We had blood culture tube shortage.
Yeah, so that was a nationwide shortage from
Yes.
the manufacturer that we use for our blood cultures. It was just a manufacturer problem that they had being able to get the raw supply to make the blood cultures. Thankfully, we were able to maintain good enough supplies here on hand that we were able to just continue some best practices with our blood cultures, and we weren't in such a hard spot. There was other facilities around the country where I heard that they were completely out of blood
Yes, I
cultures,
heard that
and
too.
I mean, just awful.
Yes.
Thankfully, we did not have to stop doing blood cultures.
Yes.
We did not reach that point, which was
Yes.
good for
Yes.
us. But it did allow for us to evaluate how we were using blood cultures and some of our best
Right.
practices for using blood
Correct.
cultures, which I think was good for us to evaluate some of that, just that diagnostic stewardship for
Yes.
that best practice.
That's so important, because I think when the shortage came up, and we worked collaboratively with lab and IT and came up with best practice alerts to drive when blood cultures are indicated, when they are not indicated. there were so many opportunities we identified, and we saw a significant reduction initially during the critical shortage.
Right. I mean, very first off the bat, we saw a 60% reduction in
that's
utilization
significant.
of blood cultures. It was huge. And even with that reduction, there wasn't a whole lot of, we're not getting blood cultures. We didn't get a whole lot of that because we do get those phone calls like, I'm not getting my test. We will get you your blood cultures, I promise. And that wasn't the complaints that we were getting because we could still do blood cultures at that time. We just had put some best practices in place for it. So it was great that we were able to do that part of it. I think overall, I think it just brought to light how, I know how easy it is to maybe want to overtreat or maybe overcall some of the things that we were doing just for the betterment of what we're doing. But I think it was good to bring light to that situation.
And even through the critical shortage time, we always recommended in patients with suspected sepsis that blood cultures are drawn prior to antibiotics.
Correct.
So that best practice we continue to emphasize and recommend. And I think the opportunities we really identified was where repeat blood cultures may not be needed, like uncomplicated gram-negative bacteremias, or patients with non-severe community-acquired pneumonia or skin and soft tissue infections, where we don't really need to be getting blood cultures. So I think there were several opportunities we identified, and that really helped also. Diagnostic stewardship, again, always ties to what we do with infection control and antibiotic stewardship. So I hope the diagnostic stewardship for blood cultures continues. So I know there has been recent discussion about not getting rid of the alert, but just alerting it or adjusting it, editing it to make sure that even if the shortage has resolved, this is still the right thing to do. As we focus on the CLABSIs this fiscal year, and we should be doing it all the time, anything else we have not touched on that you want to bring up? Nicole, you or Sarah?
I kind of like Sarah's thoughts on how a hospital this size, how many different departments work together to reduce a CLABSI. Do you want to expand on that?
Well, I guess my point on that is just that it's so many people's responsibility for it. It cannot be just one department. There's so much that comes together with it. There's so much data that can come together with it to show to show where we can make improvements, to show best practices, to show new techniques that might come out, to show new methods that might be out there, or new standards that might be available for the different practices. I work in the lab. I do not have direct patient care, so I cannot tell you how to place a central line or which central line to use, and I don't pretend that I know how to do that at all. But I am sure that there are, different products out there, and they may be improving with each year, and new manufacturers and new techniques and things of that nature. And so there's going to be collaborative efforts with, nurse educators and
vascular access teams.
And those personnel who can bring that information to the table, and it's going to be part of our infection prevention team and with our lab data and our, all the different teams that have to come together so that we can work to reduce these numbers. And then not only just within the one hospital that we work at, but we are a 5-hospital system. So we want to make sure that our best practice that we do at one hospital can then be utilized at our other hospitals, regardless of whatever size hospital you are. And then if that works across our hospitals, if we can share that amongst other hospital facilities, then that's great. We should be sharing that across other hospital facilities.
Absolutely. I think CLABSIs are one that I believe strongly that we can get to zero. If we follow the best practices in CLABSI prevention bundle, and the bundle has elements of insertion, maintenance, and it's called a bundle because we have to follow each of the components in that to see that positive outcome, which is prevention of infections. Some of the things we also have been doing for years or continue to do is also promoting midlines. So Nicole, from a surveillance standpoint, midlines will not meet criteria for CLABSI.
That is correct. So it's a line that terminates in a greater vessel. So that would be including PICS. They do terminate in a
PICS do,
greater
yeah.
vessel. So yes, please promote midlines that way.
Yes.
It's better for the patient as well. You know, we're not
Right.
putting them at risk.
Yes. And also using ultrasound for line insertions.
Yes.
That's another thing we also, it's part of our bundle.
Yes.
That we use ultrasound. Speaking of lines that meet criteria for CLABSI versus not, what about ECMO?
So patients that are on ECMO do not meet for HAIs at this point.
Okay. Thank you for clarifying that.
Yes.
Can you touch a bit on HOB, hospital onset bloodstream infection? Because we keep hearing about that.
Yeah.
That CDC is
Yeah.
looking into changing the definition for CLABSI. So
Yeah.
what are we looking at and when?
So right now it is it's healthcare onset bacteremia, and what I've been able to find, because right now they are bringing it to some facilities and trying it out, so it's been a little hard to find a little bit of that on it.
Okay.
But it is healthcare onset bacteremia, and that means a patient with a positive blood culture, either to common commensals or an identified organism, will that is drawn after day 3+ of hospital stay, will get an alert that they have an onset bacteremia. And so the hospital has to own that okay, maybe we need to look at something to see what's do a little vent huddle, what caused this actual bacteremia. And so what I can find right now is that we will still have CLABSIs current that we will monitor, and then we will have healthcare onset bacteremia. So it'll kind of be like how all my NHSN people know this. It will be submitted kind of like how MRSA and C. diff is submitted. It's hospital-wide. It's not unit-based.
Yes. Okay. Because one of the things that we notice is that bloodstream infections occur in patients who may not have a central line.
Yes.
The source could be a peripheral IV.
Yes.
So the way we insert peripheral IVs, the way we care for them should be the same. I mean, we should be very cautious about any line. If it's needed, it should stay. Otherwise, it should be removed.
Yes.
And line assessment is so important. Looking visually at the line to see if there is any redness, any swelling, any pain, and reviewing that with a provider, and actually discontinuing it if there are any signs of phlebitis, like inflammation or infection early on before they develop the bloodstream infection, is very important. And there are also other causes of, it could be a urinary tract infection, not necessarily a catheter associated, that could lead to a bloodstream infection or a pneumonia in a patient who is hospitalized, not necessarily a ventilator associated pneumonia. Could lead to translocation and bloodstream infection. So I think this new definition, once it's finalized and as we look into that, then those numbers will be much higher than central line associated bloodstream infection. So all the more important, again, as patients stay in the hospital, to make sure that patients only have those lines and catheters that are absolutely needed. They're removed timely if they're not needed anymore, and draw blood cultures when clinically indicated, right? And all these other best practices that we discussed. Anything else, last words from either of you?
I will say that when a CLABSI is identified, we, infection prevention, sends it to nursing leaders, and they do a real deep dive on the patient. What could we have done different? That way we improve our practice to prevent this in the future. We call those event huddles. And so once the workup is done, we all come together. It's a multidisciplinary team. We all come together and we talk about what we could do better in the future. So any hospital that doesn't currently do that, I highly recommend it, because you can really dig into making your bundle better, or improving other HAIs and things like that.
And I think that also goes back to what Sarah mentioned earlier about this multidisciplinary
Yes.
collaboration. The CLABSI work group has representatives from so many different departments.
Yes.
And when we do the event huddles also, we have representation from so many different areas, which really helps us to know why this patient developed this infection and see what opportunities we have, because any change we make at that time will help so many other patients.
Yes.
Anything from you, Sarah?
No, I mean, I think that it's just good practice to, make sure that you're following even your basic hand hygiene and basic,
So important. Yes.
just basic cleaning techniques as you're getting your blood cultures,
Yes.
because getting those skin commensals, that does make a difference in counting your CLABSI numbers, and that does make a difference on that part of it.
Thank you. Thank you for sharing that. Thank you both for joining me today as we discussed about CLABSIs, and hopefully this information will be helpful for those listening in. And thanks again.
Thank you.
Thank you.
Thank you.